Hello, everyone. I hope that you all are doing fine, and I'm also fine. All right, so we will start from today's pages, which is we need to start corticosteroid topic. This topic covers practical information on using corticosteroids in dentistry. For comprehensive drug information, including precautions, contraindications, adverse effects, and drug interactions. Consult an appropriate drug information resources. Okay. Then, if prescribing a corticosteroid, consider the benefit harm profile of the drug in the individual patient. This requires knowledge of the patient's medical history. We will read this paragraph, I think, with every medicine we are going to prescribe. We need to make sure his medical history. If the patient is taking any other medication, including prescription medication, over the counter medication like Panadol, and any complementary medicines like for a female, for example, the contraceptive pill. So we need to inquire about all those things because there are some interaction that can happen between the drugs. So corticosteroids are used in the management. So where we will need to prescribe corticosteroids to the patient, in which cases in many dental and oral mucosal inflammatory conditions because it acts as anti-inflammatory. So the routes which are available is the topical one, intradental and systemic. So in dentistry and as a general dentist, we do not really prescribe any systemic corticosteroid. We either give the topical one or intradental while doing root canal. We use the material that does contain corticosteroid in them. But systemically, like oral root or IM or IV, we cannot really prescribe it. The route of administration should be tailored to the clinical situation. Like route would depend on in which situation you need the corticosteroid, right? In dentistry, intradental or topical corticosteroids are preferred because they are associated with fewer systemic adverse effects. You all know that corticosteroids is a very big drug, and it can suppress patients' immunity, right? So we for the dental use, we do not really need to prescribe any systemic corticosteroid. We like topical or intradental is like it's enough, and a local effect is often sufficient. Local intraoral injections of corticosteroids is not appropriate nor recommended for dental procedures. So we are not injecting any corticosteroid. So in brief, we will use corticosteroid either via topical route or via intradental route. Okay, then topical corticosteroid used in dentistry. In dentistry, topical corticosteroid, for example, creams, ointments, mouthwashes, sprays. So in topical form, they are available in these ways. Like they are available as creams, as ointments, as mouthwashes, as sprays. Are used to manage the symptoms of immune mediated oral mucosal condition. So this is mainly used for oral mucosal condition. Okay, then including conditions that present with recurrent or persistent oral ulceration. For example, for oral ulceration, we do sometimes prescribe the patient topical corticosteroid. Although there is a substantial clinical experience with intraoral use of topical corticosteroid, this practice is off-label and supported by little published evidence. In the general practice setting, only mild or moderate potency corticosteroid creams or ointments should be used. Potent or very potent creams or ointments or other formulation of topical corticosteroid should not be started without specialist advice. So, okay. So with the corticosteroid, we are only using it either topically or intradentally. Okay. So in topical form as well, we can only prescribe this mild and moderate doses. We cannot prescribe these potent and very potent. So we only need to learn these doses. Okay, which is mild one is hydrocortisone acetate, and moderate one is triamcinolone acetonide and betamethasone valerate. And you need to learn its concentration as well. So if its strength is 0.02%, 0.02%, and 0.05%. Because if the betamethasone valerate concentration increases to 0.1%, then it would come under potent drug. So you need to remember. But to be honest, for the exam point of view, I think if they in any situation, if we need to prescribe any topical corticosteroid, then we are only prescribing this 1% hydrocortisone acetate. Then topical corticosteroids are more potent when applied to the oral mucosa than when applied to the skin, because in oral mucosa, you all know, there is much absorption, so that's the reason it would affect like better. All formulation in this table are available as both cream and both as an ointment. So, for prolonged or sustained use of moderate, potent, or very potent topical corticosteroid requires regular monitoring, and use of these higher potency corticosteroid increases the risk of systemic absorption. So, now they have written, even you are giving the patient the moderate, potent, and very potent corticosteroid to apply topically, still there is a chance of a systemic absorption, either through the oral mucosa or if inadvertently swallowed by the patient. And adrenal suppression has been documented with the use of high potency topical corticosteroid. And with the high potency corticosteroid, it can also lead to adrenal suppression, which is the major side effect of this drug, which you all know can call it, can it is an like emergency condition where it can uh, cause hypotension, GIT symptoms, and patient can collapse. Then there are some other disadvantages, which means there is increased chance of superimposed candidiasis, because we all know that these corticosteroid lowers down the immunity. So if the immunity is low, there is a high chance of these fungal infection, right? And as we are applying it over the skin or over the mucosa, so there is a chance of mucosal atrophy, capillary fragility, telangiectasia, delayed wound healing, and altered pigmentation. Predisposing factors for candidiasis include, like, if the your immune is compromised, or if there is any, patient is smoker, he uses dentures, or there is a hypersalivation. In these patients, the chances of getting the patient candidiasis is more. Okay, select a topical corticosteroid based on its potency. Like, for example, it is mild, moderate, potent, or very potent. Then lesion size and location, and the patient's preference and ability to adhere to instructions. Creams are water based and easily applied to the oral mucosa, whereas oil based ointments may be more difficult to apply. So if you need to, because we read here that these formulation are available in both ways, like either cream or ointment. So here they states that the cream one is easier to apply by the patient. However, patients may have a preference because of taste, texture, or ease of use. But it all depends on patient. They do vary. Their thoughts do vary. So whatever they like to have, they can have, because they are available as both ways. The patient's pharmacist or medical practitioner may not be familiar with intraoral use of topical corticosteroid. Provide patients with, so what points you need to tell your patient whenever you are prescribing him the corticosteroid is, it is not necessary to dry the mucosa first. Like, it is not necessary to hold it or dry your mucosa with the cotton or something. You can just apply it to the lesion. Apply a pea-sized amount of the cream or ointment to a clean fingertip. Then smear a thin layer onto the affected area. Okay, and hold in the mouth for 1 to 2 minutes without swallowing. Like, try to increase the contact time, so it would affect more, and then spit out excess. If you find it in excess, you can advise your patient to spit out. Like, do not swallow, right? Follow the dentist instruction for frequency of application, and ideally apply the corticosteroid after meal or oral hygiene practice. So this point is just for like it would adhere to that lesion for the longer time, because for example, if we have any meal or something, it would go away, right? So we can, there is a chance of swallow. So whenever you are finished with your meals or finished with your brushing, then apply. Although the cream will be labeled for external use only, use on the oral mucosa is safe, because in some creams or in some ointments it is written like it is for external use only, but still you can use these formulations for intraoral, like on the mucosa. It is completely safe. Systemic absorption from the mouth is minimal if used as instructed. Okay, so we read about the topical part. Now is the intradental corticosteroid. Okay, so in the intradental corticosteroid and antibiotic combination can be used to manage pulp and periapical diseases. We all know this is the ladder mix, right? So ladder mix does contain corticosteroid and the antibiotic combination, which is used for pulp and periapical diseases, right? Which are caused by bacteria and inflammation. Dental treatment is also required. And dental treatment is also required. Only putting these intradental corticosteroid is not really helpful. Two forms of corticosteroids and antibiotic combinations are commercially available for intradental use. There are two forms of intradental which are available. One is in a paste form and other one is in the cement form. The form used depends on the condition being treated and where the compound need to be placed. We all know like the paste, we can only use it for the like endodontic procedure, or if there is any like during endodontic treatment, or to reduce periapical infection like into the canals, we will use the paste, right? To prevent and manage severe form of root resorption and inflammatory root resorption and external replacement resorption. But while the cement, it does contain calcium hydroxide, zinc oxide, and eosinol as well, and it would be used as cavity liner or base, and it can also be used as a part of indirect pulp capping, as in direct pulp capping, and as a pulpotomy agent. Okay, so for the intradental, it is two type, either used as water soluble paste or a hard setting cement. Paste contains the its combination is sorry its composition is triamcinolone with clindamycin or declomycin, right? So this is corticosteroid and this is antibiotic, so it does contain that combination. And then we can use it for the root canal purpose, for to reduce periapical inflammation and pain in irreversible pulpitis or infected root canal system, then to prevent and manage several form of inflammatory root resorption, then external root resorption, and then there is other form which is the combination corticosteroid and antibiotic cements. So the cement form we will use either as a liner, as a base, as IPC, DPC, or pulpotomy. Okay, so just try to remember, like we will use cement in the case of lining, and IPC, DPC, and pulpotomy, and we are using the paste in the canals, like in during the endodontic treatment, during the periapical inflammation, or root resorptions. Then systemic corticosteroids used in dentistry. Systemic corticosteroids are rarely appropriate for treating oral or dental condition because they are associated with significant adverse effects. Okay, local applications are usually effective. Systemic corticosteroids should only be prescribed by a dental specialist. So you won't be really prescribing any systemic corticosteroid to the patient. Indication for systemic corticosteroid include this is prescribed by the specialist, and they only prescribe this medication in certain situations. For example, severe post-operative swelling, severe trauma, periapical nerves sprouting, and acute apical periodontitis. Okay, and inflammatory mucosal diseases. All right, so this topic ends here, and now the mouthwashes. So this paragraph is same for every drug. You need to consider the benefit and harm profile of the drug in the individual patient, and then you need to check about the medical history, concomitant medications including prescription, over the counter, and complement medicines. Okay. Then mouthwashes which are used in dentistry. So there are several types. First of all, the antiseptic mouthwash. It is mainly used to decrease the number of microorganisms in the oral cavity, and it can be used for periodontal diseases, dental caries, pre and post procedural mouth rinsing. So the antiseptic mouthwash are antiseptic mouthwashes decreases the number of microorganisms as its name states, right? Antiseptic mouthwashes can reduce plaque formation but do not reduce existing plaque. So if there is a plaque which is present already present on the teeth, it cannot remove that. It can only reduce the formation of the new plaque, which must be removed by the. That's why scaling and cleaning is really important. You need to clean the patients with the either the ultrasonic or the hand scaler, whichever it is, and then you can, as an additional measure, you can prescribe the chlorhexidine for some time, like for 2 weeks, I believe, but I'm not 100% sure. Either it is 1 week or 2 week, because there is some disadvantages that it can stain their teeth. Okay. Um, Antiseptic mouthwash is not required as a part of standard oral hygiene routine. It is not required that you need to uh, rinse your mouth daily with the chlorhexidine. It is only required in certain situations and for limited time. The use of antiseptic mouthwashes in periodontal disease is controversial. They are only effective against supragingival plaque and are not effective beyond the gingival crevice or periodontal pocket. Okay, so for this, you need to advise your patient to come for cleaning, scaling and cleaning. Patients should be informed that the principal treatment of chronic periodontal disease is professional intervention with debridement of involved. So whenever, like it is, I think it is same like caries. So for the caries also the the treatment that you need to do is the like if the patient comes with the pain, the best thing is the dental treatment only. The medicine are only as a additional thing, right? So same here in perio cases, the best thing is the mechanical debridement, but as an additional measure you can advise your patient to use this chlorhexidine mouth rinse. Okay, and then although they are not appropriate as the sole treatment for periodontal disease, antiseptic mouthwashes can be beneficial in some circumstances. For example, short-term use in gingivitis or necrotizing ulcerative gingivitis cases when inflammation, when there is in necrotizing gingivitis, we all know that there would be a lot of inflammation and patient would be in a lot of pain, right? So that so we need to remove that plaque and that bacteria, so it would act as additional measure. Then chlorhexidine, they have discussed in detail about the antiseptic mouth rinses, which are of two types, chlorhexidine and the hydrogen peroxide. Chlorhexidine, it has bactericidal and fungicidal properties, and so it also acts against some viruses. Chlorhexidine absorbs onto the oral surface, so is effective over a prolonged period. It prevents plaque formation on a clean tooth. So it only prevents the formation. It does not reduce the existing plaque. The concentration which is used in dentistry is 0.12% and 0.2%, which is available as gel, slow release formulation for local delivery into periodontal pockets. Okay, and then it was previously thought that chlorhexidine mouthwash was inactivated with the detergent which is present in the toothpaste, which is the sodium lauryl surface, but now it states that it is not the case. Although it is unlikely that there is an interaction between sodium lauryl sulfate and chlorhexidine, further evidence is required to confirm this. So chlorhexidine disadvantages are it can lead to skin reactions, it can irritate mucosal surfaces and interrupt wound healing. So if you have extracted the tooth, you do not advise the patient to rinse his mouth with the chlorhexidine. You only advise the patient to rinse with the warm saline rinses. Okay, because it has the property to irritate the mucosa and it can also interrupt with the wound healing. Intraoral use can cause a burning sensation, alter taste, and increase the calculus formation. It can also cause brown discoloration of the teeth, tongue, buccal cavity, and margins of the restorations. So extrinsic staining is not permanent and can be professional. It can be removed, but it is a disadvantage that it can lead to the staining. But it is usually recommended to take it only for the 2 weeks, which would not really cause these side effects. Chlorhexidine allergy has been reported, sometimes so severe as to be life threatening. Life some I'm so sorry, sometimes so severe as to be life threatening. If a patient reports a history of chlorhexidine, then it must be avoided. If the patient has allergy history of allergy, then you should not be prescribing him through any of the route. Okay. Then the other antiseptic mouthwash is the hydrogen peroxide. It also has the antiseptic property. It is used in the concentration of 1.5%, and it in this concentration it does not adversely affect the hard or soft tissues of the mouth. However, if the patient would take it in the higher concentration, which is the 30 to 35%, which is mainly the concentration used in bleaching products, it can lead to mucosal burns, reversible hypertrophy of the papilla of the mouth, and can occur with the continued use of a hydrogen peroxide mouthwash. So there are some other antiseptics also which are available in the markets. Other are cetyl pyridium chloride. It is also an quaternary ammonium compound. It has surfactant, detergent, and antibacterial property. It is available as mouthwash, gargles, and lozenges. And some formulation also contain local anesthetic or an anti-inflammatory. Okay, and the other part is the povidone iodine. It has antibacterial, antifungal, and antiviral properties. It is available as mouthwash and gargle. It can lead to irritation of the skin and the mucous membrane. It is absorbed through damaged skin, so application over a large area of broken skin is not at all recommended. Povidone iodine should not be used during pregnancy or lactation because it can cause hypothyroidism in the neonates. Okay, mouthwashes containing essential oils like eucalyptus, menthol, thymol, methyl salicylate have been found to have antiseptic properties, and it also reduces plaque formation, but there is limited independent evidence of benefit. And the triclosan is not at all recommended. Okay, so these are the type of antiseptics which are used in dentistry, but more likely we are prescribing chlorhexidine, and in necrotizing ulcerative gingivitis we can also prescribe hydrogen peroxide or chlorhexidine. It's your choice. Okay, then the other mouthwashes which are used in dentistry are the fluoride mouthwashes. They are helpful in patient with high risk of dental caries, but should only be used on the recommendation of a dentist. Okay, and with the fluoride, we all know that the fluoride reduces the incidence of the dental caries. Topically applied fluoride promotes. It acts like it will help in remineralization through the formation of fluoride-containing apatites, which are the fluorohydroxyapatite and fluoroapatite, which are more resistant to future acid and than the normal components of the tooth enamel. Then fluoride ions have an antimicrobial effect as well at higher concentration with the low pH. Like if we use the acidulated phosphate fluoride, it also has the antimicrobial activity as well. And we all know that the fluoride is available as toothpaste, mouthwash, gel, foam, varnish form. Okay, and the recommendation does vary according to age and the risk of dental caries. And there is one other component which is the CPP ACP. It is basically a milk protein made up from calcium and phosphate ion, which combine with fluoride to promote the enamel remineralization. CPP ACP formulations include, it is available as sugar-free chewing gum, paste, varnishes, some of which also contain fluoride. So avoid CPSP in patients who are allergic to milk protein. You need to find out if the patient is allergic to milk. So in those patients, you want to be prescribing CPP ACP, and it is only a adjunctive to fluoride treatment. Fluoride is always best, and it is a additional. Okay. Then anti-inflammatory and analgesic mouthwashes, which is the benzidamine. It provides symptomatic relief of some inflammatory oral mucosal diseases. So it is anti-inflammatory mouthwash. This we generally prescribe in oral mucosal lesion whenever the patient complains of pain, because it is a type of NSAID drug. So it would help in relieving the pain. Okay, benzidamine formulation include, it is available as mouthwash, gel, spray, and its concentration is 0.15% to 1%. Some formulation also combine benzidamine with an antiseptic. Local adverse reactions of benzidamine, its disadvantages are like numbness, burning, erythema, and rash have been reported, occasionally reported. Systemic adverse reactions are uncommon. Then other are the lubricating mouthwashes like artificial salivary product we and sodium carbonate. We generally prescribe for the like some duration temporary relief of dry mouth. And then alcohol containing mouthwashes may be associated with oral cancer and should be avoided. We do not really prescribe any alcohol containing mouthwashes. And in addition, patient with oral mucosal disease and dry mouth should avoid alcohol containing mouthwashes, because this would lead to additional drying of the oral mucosa. Okay, so we are done with this chapter. So tomorrow we will start the caries chapter. Okay, so thank you so much, guys, for watching my videos, and I really hope that you are enjoying it and you are getting some benefit from these. If there is any friend or someone with whom you can share and spread these videos, I would be very grateful to you. And thank you so much. We'll see you next time. Bye bye.